Hello, good afternoon, everyone. Welcome to our Health and Social Services Subcommittee briefing on the Maryland Department of Health budget overview. Thank you so much to our Department of Legislative Services, who has provided an incredibly thorough analysis for our review. We will have you join us at the table here to be able to go through that analysis. And I understand each of you have different components, so I will just, when you're seated and ready, I will just turn the floor over to you to do your magic. Thank you.
Thank you, Chair Shetty. My name is Naomi Camaro. I'm a budget analyst with the Department of Legislative Services, and I'll let my two colleagues introduce themselves.
Hi, my name is Ann Braun, also with the Department of Legislative Services.
Hello, my name is Victoria Martinez, also with the Department of Legislative Services.
We're going to be presenting the Maryland Department of Health overview budget. So starting on page 2 of your document, you can see a chart of 3-year funding trends. Overall, department-wide, the fiscal 25 budget decreases by $261 million to $19.6 billion. And we'll get into some of those changes in just a moment. Turning to page 4, we have a list of proposed deficiencies for fiscal 24 included in the fiscal 25 allowance, totaling $635.3 million across the department. Most of this is driven by shortfalls in Medicaid services. There's $420.6 million in total funds to account for fiscal 24 shortfalls in Medicaid, and then $204.3 million to account for shortfalls related to fiscal 23 services. Victoria will walk us through some of the COVID funding on the next page.
I'll be talking briefly about the COVID-19 federal stimulus funds. Between fiscal 2021 and 2024, MDH received COVID-19 related federal funding due to the public health emergency through different stimulus bills. The largest increase in federal funding was a 6.2 enhanced federal match on qualifying Medicaid expenses through the Families First Coronavirus Act of 2020. The additional federal fund matching reduced the need for general funds in those years, and this federal support was phased out and fully expired on December 31st, 2023. Similarly, the American Rescue Plan Act included a 10% enhanced federal match on home and community-based services spending. General fund savings from the enhanced match had to be fully reinvested in home and community-based services by March 31st, 2024. In fiscal 2025, MDH is still spending $48 million in remaining federal funds from other stimulus bills and sources like CDC grants that are shown in Exhibit 1, but at a decreased amount compared to the $138 million budgeted in fiscal 2024. As shown on this exhibit on page 5, the fiscal 2025 allowance still includes additional federal funding from the ARPA, CARES, and Coronavirus Response and Relief Supplemental Appropriations Act stimulus bills. These federal funds support public health activities such as COVID data reporting, vaccine outreach efforts, and public health workforce support. So this decrease in federal funding contributes to the overall reduced MDH spending in fiscal 2025. So I'll turn it over back to Naomi.
Thank you. On page 6, you can see a breakout of department spending by purpose for fiscal 25. So from the pie chart, you can see that a large majority of the funds in the Department of Health are allocated toward direct medical services. 88% of the budget is going toward provider reimbursements in Medicaid, behavioral health, and DDA. There's also 4% of the budget dedicated to staffing, and about half of that is staff at the state inpatient facilities. The next page, page 7 through 9, outlines the major changes between the fiscal 24 appropriation and the fiscal 25 allowance. Again, the entire budget is decreasing by $260.1 million, or 1.3%. And that decrease is driven largely by lower enrollment in Medicaid, totaling a decrease of $552 million, which is partially offset by provider rate increases for Medicaid, as well as increased costs for personnel. I'm going to talk a little bit about personnel in a couple minutes, but essentially the Department of Health is adding many new positions, and of course that's adding to the budget. There's also a small decrease due to the expiration of COVID funds, as Victoria just explained. And then on page 10, we've listed out the contingent reductions included in the budget. So the 25 allowance includes language that reduces general funding in 3 programs for a total of $15.7 million. Contingent on the enactment of certain pieces of legislation. The largest of these is related to the Family Act, and so this piece of legislation would require the Department of Health to take on the employer share of family and medical leave insurance for some service providers, and so the fiscal 25 budget includes $12.4 million pending legislation that would delay that act. Now I'll turn it to Anne for our Medicaid discussion.
Great. So at the bottom of page 10 begins a brief update on Medicaid enrollment. And so then turning to page 11, Exhibit 2 shows monthly Medicaid enrollment starting in January of 2020. During the COVID-19 public health emergency, Maryland was required to freeze Medicaid disenrollments as a condition of receiving that 6.2% enhanced match that Victoria mentioned. And so as a result, enrollment grew by about 29% from just under 1.4 million enrollees in January 2020 to almost 1.8 million in May of 2023. Starting on April 1st of 2023, MDH initiated a 12-month unwinding process to redetermine all of Medicaid participants' eligibility. Under that schedule, the first disenrollments took effect at the end of May, and so that's why you're seeing June show the first decrease in enrollment. So then turning to Exhibit 3 on the next page, this shows average monthly Medicaid enrollment in each fiscal year, and so for fiscal 2024 year to date, you're seeing the first set of impacts of the first half of the unwinding period, so there is a slight decrease in enrollment so far. And then compared to the prior year, the budgeted enrollment decreases by about 5.3% in fiscal 24 to 1.66 million Medicaid enrollees, and then decreases further in fiscal 25 to 1.59 million. And that's due to the unwinding process continuing in fiscal 24 and then favorable economic trends that are both expected to decrease Medicaid caseloads. And so this reduction in budgeted Medicaid enrollment is, as Naomi said, the largest driver of the overall decrease in MDH's budget. I'll pass it back to Naomi for personnel.
So our personnel discussion starts on page 13. First, I'll highlight the vacancy rates. In recent years, the Department of Health has carried vacancy rates above budgeted turnover. But as you can see in Exhibit 4, as of December 2023, in the fiscal 24 year, that vacancy rate has actually decreased by 3 percentage points compared to the year prior to 11%. And as of this month, the vacancy rate has decreased further by a couple fractions of a percentage point. And so while there's more authorized positions in fiscal 24 and fiscal 25, the vacancy rate is decreasing. In some offices, as you'll see in later analyses, the vacancy rate is pretty high, but overall decreasing. The second thing I want to point out is the new positions that the Department of Health is adding in fiscal 25. This analysis was written when we first received budget data, and we've since received revised data. And so I just want to clarify that the actual number of new positions added in fiscal 25 department-wide is 453. And I also want to point out that through 2 different Board of Public Works authorizations, the Department of Health was able to convert contractual positions to 279 regular positions in fiscal 24. The department also noted that a lot of these positions were filled and just turned into regular employees rather than being vacant. On page 14, Exhibit 5 shows the list of new positions and contractual conversions. Again, this chart is using the first set of data we received, so the number of new positions doesn't quite match what I'm saying. The largest driver still is in facilities, which is where a big majority of the new positions exist, or the staff that are employed at the various state facilities. On page 15, this exhibit shows where the positions that were converted sit in fiscal 24. So again, a lot of contractual conversions among the 11 state facilities. I'll turn it back to Anne for the next section.
Great. So the issue section begins on page 16, and to go over the first issue, page 16 lists Maryland's Medicaid waiver programs that provide home and community-based services. Those include things like case management, personal care, and nursing to help waiver participants live at home or in a community setting instead of a nursing facility or a state health facility. The Office of Long-Term Services and Supports under Medicaid manages 3 of the waivers, including the Community Options Waiver. DDA manages 3 of the waiver programs, and then MSDE administers the Autism Waiver. So I'll jump to Exhibit 7 on the next page. This shows the number of individuals on registries and wait lists for the Community Options, Autism Waiver, and DDA waivers. Under the Community Options Waiver, there's been a significant increase in the registry of about 41% from fiscal 21 to fiscal 23, where there's now over 25,000 individuals on the registry for that program. I will note the Autism Waiver also reported a 7% increase over the period shown, and had a registry of 6,705 children at the end of fiscal 23. So despite having this growing registry in the Community Options Waiver program, MDH has not filled its authorized 6,350 slots each year. The most slots that MDH has been able to fill is just under 4,700 slots in fiscal 22. And on page 18, there's a list that shows reasons that MDH has previously given for not using all of its authorized waiver slots. So just to highlight a few, the provider network has limited capacity to be able to serve waiver participants in addition to serving people receiving these services through the entitlement programs. And then the Community Options Waiver has a complex eligibility screening process, and in combination with high vacancies among eligibility determination staff, that has also caused administrative delays. So then turning to Exhibit 8 on page 19, the left 2 bars show that MDH has performed outreach to the registry by sending out 300 applications per month in calendar 2022. But recently, Chapter 738 of 22 required MDH to increase that outreach to 600 applications each month. And so MDH started sending out those 600 applications per month in November and has plans to increase this further to 700 applications going out each month once staffing levels improve. The exhibit also shows, with the diamond and triangle markers, that less than 40% of applications have been returned of those applications that were sent out in both years. The 3 sets of bars on the right show that the outcomes on average for each month for those returned applications. And so I'll highlight that in calendar 22, even with only a little over a third of applications being returned, at the end of each month, MDH would still have about 39% of those applications pending without an eligibility determination. So MDH attributed these processing delays to high vacancies among the staff that support eligibility determination for the Community Options Waiver. And in September 2023, MDH had reported that there were 30 total vacancies of that group, including regular and contractual personnel. So then turning to the next page, this begins a discussion on another 2022 bill, the End the Wait Act, and that bill required MDH to develop plans to reduce wait lists for HCBS waiver programs by 50%, with the plans beginning in fiscal 24. And so for the autism waiver specifically, that plan was, their plan was required to include conducting eligibility screening while children were still on the registry, and then serving at least 50% of those who were determined eligible starting in fiscal 24. And so these reports were from MDH and from the State Department of Education were submitted in February 2023. Exhibit 9 shows the proposed plans for each waiver in terms of how many individuals would be enrolled each year and what the cumulative cost to the state would be through fiscal 28. For programs like the Community Options Waiver, the number of enrollees takes into account the lower percent of registrants who eventually are determined eligible and who enroll. So it does take into account like the uptake of that waiver program. Across these plans, the autism waiver accounted for more than half of the state costs, but that's mainly due to the requirement that the program serve 50% of those determined eligible starting in fiscal 24. I will note the costs listed here also include increased staffing needs under each of the waivers and Central A for eligibility determination. The reduction plans mention the need to support HCBS providers to increase capacity, but the plans didn't describe specific activities or provide a cost estimate for those activities. And most recently in fiscal 24, there was $6 million budgeted in the dedicated purpose account for End the Wait activities. And the fiscal 25 allowance includes another $10 million for provider recruitment strategies and capacity building. So MDH is asked to provide an update on its efforts to fill vacant positions that support the waiver programs and to discuss whether there are new positions in fiscal 24 or 25 as outlined in the reduction plans. And then finally, to describe how that $10 million for capacity building will be used in fiscal 25. So that concludes the first issue on HCBS waivers. I'll transition right into issue 2. And so that begins at the bottom of page 22, discussing provider rates and rate setting. The fiscal 24 budget included language that restricted $250,000 in general funds until MDH submitted a report on the current rates and recent rate increases across Behavioral Health Administration, Developmental Disabilities Administration, and Medicaid. So Exhibit 10 on page 23, this shows rate increases specifically for providers that have received mandated provider rate increases over the past few years through legislation that increased the minimum wage. So this includes long-term service support providers in Medicaid, behavioral health, and DDA providers. On this chart, the rate increases in italics were mandated, and I did want to highlight that some HCBS providers in particular received additional rate increases, and those were federally funded through the American Rescue Plan Act with the enhanced match that, again, Victoria had mentioned earlier, provided throughout the public health emergency. And so those rate increases for specifically HCBS providers are starred in this chart. Most recently, these providers received an 8% increase on January 1st, 2024. That reflects the accelerated rate increases that were originally scheduled to take effect in fiscal 25 and 26. Those rate increases were moved up in last year's budget in line with the accelerated increase in the minimum wage. So because of that change, there was no mandate for provider rate increases in fiscal 25, but the allowance includes a 3% rate increase for these providers on a discretionary basis. The rest of this issue discusses the current rate structures and ways that rates were set across the different MDH administrations. Under Medicaid, I'll just highlight that rates, particularly for physician evaluation and management services, are often compared to Medicare rates, and in the fiscal 25 allowance, those rates continue to be funded at 100% of Medicare rates. I'll highlight under DDA that that rate system is still transitioning from a prospective system to a fee-for-service reimbursement system. And then under the behavioral health rates, I'll note that there was 2017 legislation that required MDH to conduct an independent rate-setting study for community-based behavioral health services. The department described a two-phase process for that study, with the first step being designing a cost report template. And so MDH is asked to provide an update on the status of that rate-setting study for behavioral health providers. DLS is also recommending that the budget committees release the $250,000 in restricted funds. And so if there are no objections raised, we will process a letter releasing those funds after the hearings for the MDH overview analysis. So with that, I'll turn it back to Naomi.
The last part of our presentation is the third issue that begins on page 25, which is related to the findings by the Office of Legislative Audits. So in their statewide review of budget closeout transactions for fiscal 2022, OLA included findings related to 16 Department of Health accounts and identified $3.5 billion in federal fund revenue items that lacked proper documentation. In a subsequent audit in October 2023, covering the period between February 2019 and June 2022 for the Department of Health Office of the Secretary and other units, it further reviewed MDH's federal fund accounting policies and procedures and published 17 findings on deficiencies in this process. I also want to note that yesterday OLA published their the review of transactions for fiscal 2023 and found 3 findings related to the Department of Health. And the department, in its written response, described the various efforts that it's taking to rectify the situation, including employing an outside accounting firm to review the various accounts that OLA identified issues with and try to recover the remaining federal funds. The rest of the document includes appendices which include an update on the cigarette restitution fund, as well as additional budget data, including a list of the fiscal 24 deficiencies, personnel data, and caseload data. That concludes our presentation, and we'd be happy to answer any questions you might have.
Thank you so much. Such a thorough report. We're so grateful for all of the work that you all do to help us do this important work. So I will see first if any of our colleagues have questions, and I see Delegate Heinbaugh does. You may ask your question.
Oh, thank you, Madam Chair. Almost fell asleep there. Oh. Very interesting, a lot of information, but I have a question for you. At the bottom of page 3, you have a note about the Cigarette Restoration Fund, and it says that you expect to get at least, I think, $25 million, maybe more. What happens if you receive that money after the FY25 budget has been approved? How would you, do we have a plan on how to use the money or how to spend it, or what happens if you get it after, and it's an extra 25 million? I know the restrictions on how it can be used, some of it, but what's the plan for that?
Sure. So that funding in particular, there was legislation a couple years ago that that created a separate account, and the Cigarette Restitution Fund is a special fund. So funds could be added, I believe, through an amendment. But what that legislation did was required funds received from these arbitrations must support the settlement payments to historically Black colleges and universities. And so if that $25 million was received in fiscal 25, it would specifically support that use. And yeah, I believe it would be through the amendment process that the funds would be added, but I can confirm that for you.
Thank you.
Thank you. Thank you for the great question, and thank you for the answer. I have a question for you all around Medicaid enrollment projections. So I know that the process for the unwinding has been challenging across the country, and I see that you note that the FY24 actual enrollment numbers, that they've really far exceeded our anticipated FY24 budget numbers. And so I see that we've got a pretty sizable deficiency appropriation as a result. But the FY25 budget assumes an even lower number than even the projections for FY24. So I'm just curious, what's the impact to the budget of this differential?
Sure. So, I mean, as we said in the presentation, it is, the decrease in Medicaid enrollment is driving most of this decrease in the overall department's budget. And so when we get to the Medicaid analysis, we'll have a lot more detail on the forecasting and the adequacy of the budget and things like that. So I'm happy to answer the specific budget impact there. But yeah, I mean, that decrease from 1.66 million Medicaid enrollees to 1.59 is driving most of that decrease, as the economic status is expected to be still favorable, and then any kind of lingering impacts of that unwinding process continue in fiscal 25.
Okay, thank you. Thank you. Any further questions from subcommittee members? Okay, thank you so much, GLS. Really appreciate your assistance with this analysis. I'll now call upon Secretary Herrera Scott to please join us, and anyone you wish to bring up from your team is welcome as well. Welcome back. We're really excited to have you here to begin our discussion on the MDH budget. So when you're ready, you may begin.
Great. Good afternoon, everyone. Chair Shetty and Budget Subcommittee members, I want to thank you for your time today to speak a little bit about the Maryland Department of Health and our proposed budget, as well as alignment of the funding to support the Moore-Miller administration. As always, I want to thank the DLS analysts for their thoughtful and insightful analysis. But first and foremost, I wanted to spend a little time talking about the alignment with the budget, and then I'll answer the questions. But the fiscal year 2025 allowance includes a significant investment in the MDH workforce, and it speaks to the governor's commitment to build back our workforce. Much of the workforce was really decimated, even leading up to COVID, but certainly after COVID. And as was already shared, our vacancy factor when I took over a year ago was over 14%, and in some parts of the administration, closer to 20%. But we're certainly, working to build back the department to meet the vision so that all individuals, families, and communities get the support that they need from the work that the department does every day. Hundreds of state merit positions were included in the budget, and as well as contractual conversions, and this is on top of the 280 contractual conversions that were successfully approved before the Board of Public Works. These were individuals that were in contractual positions for a very long time. We identified the funding sources and then move to convert those to merit in an effort as part of our longer-term retention strategy, but also because they should be merit employees and deserve the same state benefits as their peers. As was already mentioned, we're excited to build upon the great recruitment work that is already underway, and our vacancy factor is now down to 10%, and actually in some of the administrations below what's projected for budget, such as the facilities. We have a couple of facilities that have really just killed it with their recruitment, and we've gone below what's projected in the budget. We certainly want to thank the governor and DBM for the 3% rate increases to behavioral health providers, developmental disability providers, and other long-term care providers, and we think that will help with some of the provider shortages we're seeing. The rate increases are really, really important as we continue to build out the continuum of care that we're building in the behavioral health space and making sure people get the right care at the right place. In the budget was also an $89.2 million to maintain funding for ongoing community and crisis services that builds on the 107.5 that we got last year, and those crisis services will be coming online in summer of this year. So we will be going from 17 mobile crisis teams to I think over 40 mobile crisis teams, as well as crisis centers. In the budget, we continue to build on the public health workforce and ensure the safety of our residents. $10 million contingent on the passage of HB 583 will create a Center for Firearm Violence Prevention. This will fund data-driven, evidence-based strategies to prevent gun violence and reduce the effects of violence in our communities. I'm going to get wrong because I know the name has changed, but GOCAP, I'll just refer to them as GOCAP. I think they're back to GOCAP, although the letters don't say the same thing. But we want to complement the work that GOCAP is doing and go upstream thinking about the public health interventions that we could be doing to address the violence before it happens. Additional dollars were also identified to increase staff for the Office of Healthcare Quality to address the backlog of complaints in Maryland's long-term care facilities and to certainly ensure that the most vulnerable have a safe place to live. We know that that has certainly been a priority. In public health, we've been focused on women's health, and ensuring protection of the rights of women that we have in this state. We've not only released funds for Centering Pregnancy, which is a group prenatal care model that has incredible outcomes, including reduced C-section rates, better mother-child bonding, and a bunch of other benefits. Upstream, which is our partner working on reproductive health rights and contraception on demand, and certainly the University of Maryland to provide abortion training services so we can expand access. We've made significant statewide investments to improve access to housing for vulnerable Marylanders. We are prioritizing investments to address health-related social needs for low-income Marylanders through the current state's pilot program known as Assistance and Community Integration Services. This was previously a pilot in just a few jurisdictions, and we're now going statewide. It also allows us to leverage matching federal funds through the Medicaid program. So we certainly look forward to working with the Department of Housing and Community Development to ensure Marylanders can access and maintain stable housing. Before I close, I'd be remiss if I didn't acknowledge the budget realignment that took place, specifically in the Medicaid program. The pandemic allowed for Medicaid enrollees to remain covered through the public health emergency. So for some people, this process that we're going through on the redeterminations is the first time they're going through eligibility redetermination. And certainly for people that were used to going through eligibility redetermination, it's been years and people may have moved, changed names, things like that. But we have been leveraging every single tool in the toolbox we have to ensure that we are maintaining as many people enrolled in Medicaid as we can. We've also been working closely with the exchange when we can't to ensure that are those people now eligible for a product on the exchange, trying again to keep as many people insured as possible. As already mentioned, the budget makes adjustments to funding for services based on the enrollment trends for the first 6 months of the renewal process. Maryland was one of the states that took the 12-month option, so we'll be going through this through the beginning of June. And lastly, I want to take the opportunity to give an update on the work that we've been doing related to the financial accounting issues identified in the OLA Office of the Secretary. As part of the FY22 closeout audit, which is during the prior administration, OLA selected 16 journal entries totaling $3.5 billion attributable to various MDH programs, including $1.1 billion accrued revenue journal entry posted to federal funds clearing account. MDA was able to provide substantiation that 2.1 of the 3.5 in federal revenue has been attained through the normal drawdown process. The remaining 1.4 has been reduced to $263 million by the fall of 2023. So when we got the audit findings, we worked very closely with OLA and DBM to start rectifying the audit findings and matching the funds across the different accounts. Of that 263, we only now there are 32 million that pertain to open grants and funds that will be recovered in the near future, and 231 is associated with a sub-account balance with an overall clearing count as of FY23 closeout that is offset by revenue already received that will be a realigned prior to the closing out of fiscal year 24. So we hope to have this all resolved by the end of this fiscal year. As was already mentioned, we've brought in an outside consultant that we've been working very closely with. So not only to perform these reconciliations, but more importantly, updating fiscal standard operating procedures and business process flows. Based on some of the work that we started, it all started with one person leaving and then no accountability for the function for the person that left. And with that person went all the institutional knowledge because the work that they were doing was not documented. So now we're working on developing SOPs so that for the future, whether it's, Laura Scott or Laura Murphy, whoever comes in for that role has standard operating procedures and expectations for reconciling funds. We're also looking operationally and organizationally to how do we think about operationalizing the department and what is the right structure in our finance, fiscal staff to ensure that this doesn't happen again. So as the budget process takes place, as was already mentioned with Medicaid, each of our deputies will be before you to go further in depth in their respective administrations. So with that, I want to turn to the questions. MDH should comment on its plan to sustain its progress on filling vacancies given the addition of several hundred new positions. We've really been taking a multi-pronged approach. So we think investing in state employees and the 3% cost of living increase will help with retaining employees. Certainly the conversion to merit will also help with retaining employees. And then as far as recruiting, increasing recruitment, We have reinstated our in-person agency-wide job fairs at headquarters, as well as participating multi-agency job fairs. And we're holding hiring fairs at state hospitals, and in some cases, they've led to offer real times, especially in the state hospitals. So, and the turnout at all these events has been pretty remarkable. We have a public health workforce internship program. We are modifying job requirements, so we're looking at all our jobs to see, do you need that bachelor's for some of our more process-oriented jobs. We're also working with community colleges and high schools as we think about pathways to entry into the department. So a lot of work is happening on not only recruitment, but certainly retaining the workforce we have. Next, the question was to provide an update on efforts to fill LTSS ED vacancies, as well as describe how the $10 million in new funding in the DPA will be used to support HCS provider capacity. So on the additional funding for LTSS, or the Office of Long-Term Supports and Services, we have 8 new positions that will be started. We've again started implementing standard operating procedures, which didn't exist. We also are looking at automation. So there's a fair amount of manual processes that happen in the department. For instance, the data comes in one system, but to get it in MMIS, which is the system that pays the claims, it's a manual move of information. And so we think not only does that lead to errors, but it requires more people to do that work. We think we're going to have an automated solution in March, will then allow us to redeploy people to do more of the work on the front end to address some of the wait times that we're seeing in eligibility determination. And as for the $10 million on the direct purpose account, we're committed to working to determine the best approach to use that $10 million to support the infrastructure of Medicaid's HCBS as well as provider capacity. So there is a provider shortage. I don't know where all the providers went. The state of Maryland has not recovered post-COVID, and this is not unique to this area, home and community-based services, but the healthcare delivery system writ large. So we will certainly circle back to you once we have a thoughtful plan on what that expansion of provider capacity looks like. The next question was MDH to provide the committees with an update on the status of the rate setting study for community-based behavioral health services. We are actively engaged in procuring a vendor right now to accomplish this work, and we anticipate going before the Board of Public Works in the next couple of months, so early spring 2024. And then on the release of the $250,000, we want to thank DLS for its review. And with that, I'm happy to take any questions you might have.
Thank you, Madam Secretary. Really appreciate your thorough testimony and your willingness to engage with us as partners in this work. Do any of our subcommittee members have questions? Yes, Delegate McCaskill.
I do. Thank you, Madam Chair. Thank you for being here. Good to see you. So I have really 3 questions, but what you just said I need to digest for a second. But referring to page 8 in the DLS analysis, there are 2 noteworthy deductions, one in Alzheimer's research and then the other in the AIDS drug assistance program rebates. Can you just share a little bit more about those shifts? The down, okay, so we have
Yes.
under... Oh.
I would like to ask our Chief Financial Officer, Amelie Brandenburg, to the table to help answer that question.
Welcome.
Thank you. And actually, I'm not going to be as exciting as you'd like me to be. Can we get back to you on those?
Yes,
Okay.
absolutely,
Thank
absolutely.
you.
Well, then to my second question then. Okay, so for the FY25 budget includes a contingent reduction totaling about $16 million. Should several pieces of our legislation pass, including $12.4 million reduction to the Office of Secretary for legislation that delays the implementation of the Family and Medical Leave Insurance Program. Can you tell us a little bit more about that impact? Or
So which, go ahead,
Sorry.
you take
I'm
it.
so sorry. It's currently budgeted. Should that legislation pass, then it will be removed from the budget.
okay. So this should be removed.
And reverted to the general fund, or where will it go?
That's my next question.
No, at this point, it's budgeted, right? And
Right.
if the legislation passes and says, we'll delay for a year, then that will be removed.
Okay. Sorry, Delegate McCaskill, I didn't mean to.
Okay.
Please go ahead.
No, so I think I have my thought for this last question. When you were speaking about providers and the shortages, I had, even in my daycare for my older parents over 21 years old, and even for some constituents who have called the office and even visited, there seems to be a shortage for providers if you're over 21 years old. Could you explain that difference in that age if you under 21 and what providers may?
So I don't know about over, under, and shortages. I just know about all our shortages.
Okay.
And we have a whole workforce team now that's actively looking at this. I mean, we are doing many things, working with the different boards, even looking at our certification processes, looking at exams that people need to take, looking at loan repayment issues. Even for direct service providers, the minimum wage was increased, and then the 3% over that, because we understand, especially for many of our direct service providers come from communities of color. So we are looking at everything, but I don't have a specific answer to that question. I don't know why people left healthcare.
Okay, so that was my, not to put you on a spot moment, but just wondering, do you take any kind of exit poll or surveys of why providers may decide to leave?
So many providers left during COVID because people stopped coming for services, because we were locked down for lots of reasons, and many providers during that time just closed their doors for a variety of reasons. But again, as I mentioned, Maryland hasn't recovered the way other states have recovered. So we are working hard to bring back that workforce to address the needs. For instance, we've been working with the dean of the School of Social Work at the University of Maryland, and she said their enrollment this year is the lowest enrollment they've ever had. I don't know if school's gotten too expensive, and that's why we're seeing lower enrollments, but enrollment's down. I mean, it's being impacted across the board, and so we're actively working with multiple partners trying to address the workforce shortages that we're seeing in multiple areas of healthcare.
Thank you. That's stunning. Thank you. Thank you, Madam Chair.
Thank you, Delegate. Vice Chair Jones.
I am almost, there we are. Thank you so very much. Thank you yet again, this time on the record. All right, HCBS, waiver wait lists. So tomorrow we have a subcommittee brief. It's a joint one with Public Health. We're going to dive down a little bit more, but help me here. The waiver lists continue to grow, and yet thousands of available slots remain unfilled. The department is requesting $10 million to bolster these programs and has noted that there's a plan in the works on how to use that. Could you share details about that with us?
So the 10 million is to address the provider shortages. So the problem is that we need providers to provide the services for people on the wait list, and the providers are at capacity right now, which is why there's open slots, or one of the reasons why there's open slots. There's also open slots, as I mentioned, because we don't have enough people and we're not processing the eligibility issue. So I want to be clear about that. So there are NDH reasons for the wait list, but there are also provider shortages that are impacting getting people to services. So the 10 million is part of the dollars to develop the workforce strategy and plan to figure out how do we improve provider capacity to pre-COVID levels. Or more than that, actually, based on the number of people on the wait list.
On the wait list?
Yes.
Right. Am I allowed to have another bite at the apple? Okay. Medicaid rate review. So this actually, this situation had been brought to me previously, but I kind of wanted to dive down. MDH has been engaged in a number of significant reviews and adjustments, which is good. It's positive. for patients as it ensures that more providers are likely to provide services. The budget analysis references rate enhancements for dental services, including 9.4%, a one-time 9.4 to 20% rate increase for specific dental services. My concern here is, does that include pediatric anesthesiologists, who the children who need the most severe, the most urgent and serious of dental procedures really need that? So is that included, or?
So I'm pretty sure those rate enhancements were for primary dentists.
So it does not?
No.
Okay, thank you.
Do you have any updates that you can share about the process that you all have been going through, or anything on this? Because I know this came up in our joint briefing with HGO as well, and I had requested that information. I don't remember seeing it.
So I don't have that available. We were going to have it ready for the Medicaid budget hearing, so we can get back to you then, or we can send you written response prior to. What would your preference? Can it wait to the Medicaid budget?
It can wait.
Okay.
Yeah, thank you so much.
Sure.
Appreciate that. Joyce, do other colleagues have questions? Okay, I would like to end with a couple. I want to talk first about deficiency appropriations. And the budget reversions that happened at the FY23 budget. So specifically, MDH had some of the largest reversions, and especially so in behavioral health. And so even though we have, decreased enrollment in Medicaid, we've got a very large deficiency appropriation for Medicaid, $635.3 million, all of which would have to be spent down this year, right? By June, for an FY24 budget deficiency, correct?
Which page are you looking at? I want to make sure we're looking at the same numbers.
Sure. One moment. Let's see. Page 4 of the DLS analysis. So the first paragraph there says the fiscal 25 budget includes deficiency appropriations totaling a net increase of $635.3 million to the FY24 appropriation. Wait, so a negative deficiency to the general fund.
So this is related to the redeterminations that's happening.
Sure.
There's about 100,000 plus members that are going through redeterminations monthly, and so this is attributable to the change in the total number of covered lives in Medicaid.
Okay, got it. Okay, and then, but any further deficiency appropriation for FY24 related to these numbers would have to be spent down by the end of the fiscal year, correct?
Correct.
Okay, and then I note that there was a $35 million general fund reversion in FY23 specifically for behavioral health, but there's a $420 million, 89.1 million of which from the general fund for anticipated shortfalls for FY24. Could you provide a little bit more information about sort of the context there, what's happening?
Could you direct us again so we can
so the 30
with...
sorry. The 35 million was from the budget reversions that we met about during the interim for FY23. I think we had a joint committee hearing with appropriations and B&T that was virtual. But the $420 million number is the first bullet point. 420.6 million in total funds, 89.1 of general funds to account for anticipated shortfalls in FY24 for behavioral health related Medicaid expenditures.
The 35 million was it was part of Supplemental 5 that came down during Session 22, and it was for, I believe it was mobile crisis or crisis stabilization. And because of delay in regulations and implementation, it never got out the door, and that was the reversion of 35 million.
Okay, got it. And then
so that's different than what you're looking at here.
Okay, got it. Okay, and so are we confident then in this number that you'll be able to spend down $89.1 million of general funds by the conclusion of FY24.
So I don't like to speak in absolutes. We are hopeful. Mobile Crisis is going live in spring. We have not only, we're going, I think, from 17 mobile crisis teams to almost 40 or 40 plus mobile crisis teams. Crisis centers are coming online. We are expanding bed capacity because of our children that are unfortunately stuck in the ED. So there's a lot of activity that's happening related to that. So we are hopeful, but again, it's the timing of when some of the things go live. As far as the mobile crisis teams, we thought they'd be stood up already. We pulled the regulations back last year because the providers told us the rates were too low and it was not sustainable. We went back, sharpened our pencils, came back with better rates, put them out, met with some of the providers. They thought they were okay. So those are going out for public comment, and our goal is to go live in spring.
Okay, great. Thank you. And then that's really helpful to know. Thank you. My last set of questions are related to the OLA report reference by you, Madam Secretary, and in the DLS analysis. I just want to first take a moment to acknowledge and thank you and your team for the immense amount of work that you all have done in rectifying this situation. Certainly was very eye-opening to all of us when that report came out, and I know that these challenges preceded your administration, but you've taken a very serious look at the issue and have been very proactive in seeking to recover some of the lost funds, so thank you for that. I know that OLA provided 28 recommendations of actions that your department should take, and that the DLS analysis said that as of November, you completed 13 of them. Do you have any further updates on any major ones that remain, or when you might complete all 28?
So we are actively working, as I said, we've brought in an external accounting firm to help, and Amelie and the financial team meet weekly with the team to go through that, all the outstanding items. We are targeted for end of fiscal year 24.
Great. Okay. To complete all 28 recommendations of the OLA report.
Yes.
That's wonderful. Thank you. And do you anticipate you'll be able to recover a large portion of the remaining rejected claims? It's hard to know.
Yes, from our position at this point, from the work we've done on the reconciliations, we don't believe that there's any additional federal revenue that wasn't collected. It's just a matter of having the reconciliations.
Okay.
But
great.
and again, that's through our work to date. As the Secretary said, never want to speak in absolutes, but as it stands right now, the revenue's been obtained. It needs to be reconciled to the appropriate.
Understood. Okay. Thank you so much. Last call for questions from subcommittee members. Okay. Thank you so much. Really appreciate the department, Madam Secretary, your team, for your transparency and your hard work. And this is one of many conversations we'll be having with you all this session. So thank you so much for your participation and engagement. And with that, our meeting is adjourned.